What's good, SNMA? I hope all of you are staying home and staying safe during this time of social distancing. I know it's hard for everyone, but we're doing really well, and we all need to keep it up. Welcome to the SNMA Sowing Seeds Specialty Series. That's 4 S's, 5 S's, really. You know, we're all about alliteration over here. My name is Preston Igwe. I'm a rising MS4 at the University of Texas Medical Branch. And I am going to be your host / moderator for today's event. I'm super excited. We have 5 amazing Black psychiatrists here to speak with you today. This is all part of our Sowing Seeds Specialty Series. This is part of President Ososei's initiative for this year, where we're trying to sow seeds for pre-med and medical students, exposure to different specialties, get people thinking about, you know, what they want to do and what they can see themselves doing. So our first event today is psychiatry. So we're going to tell you all a little bit about this field and have people talk about their careers, their journeys, as well as answer some of your questions. So like I said, I'm Preston. I'm a rising MS4 at UTMB. I'm actually applying to psychiatry this fall. So I'm just as interested as you about what all these amazing panelists have to say. So please put your questions in the chat and we'll get them answered. So first we have Dr. Hairston, Dr. Danielle Hairston. She is a board certified adult and consult liaison psychiatrist. She is also the psychiatry residency director at Howard University College of Medicine. And fun fact, she is the youngest Black psychiatry program director in the country. So, you know, I have to shout her out for that because that's amazing. And we're all super proud. Welcome, Dr. Hairston.
Thank you. Thank you, Preston. I'm happy to be here.
Awesome. So next we have Dr. Donald R. Brown II. He is a board certified adult and forensic psychiatrist based in LA, and he works as an attending at Metropolitan State Hospital, as well as operates his own private practice. And also he just recorded an episode with Daddy's Issues podcast on YouTube with Tony Baker and Keon Poe, and that's available for you to watch. Welcome, Dr. Brown.
Thank you for having me, Preston, and it's an honor to be part of this conversation. Let's get it.
Yes, sir. Love seeing Black men in psychiatry. I'm telling you, inspiration.
Let's do it.
Next, we have Dr. Dajonitta Williams. She is a child and adolescent psychiatry fellow based in Houston, Texas, my hometown. Shout out to Houston. She's also the founder of the Queen Institute, which promotes mentorship, community, and wellness among teenage girls. Welcome, Dr. Williams.
Hi, thanks for having me. I'm excited about this panel tonight.
Of course. And you know, you UTMB alums and your family.
Yes, absolutely.
Shout out UTMB. Next, we have Dr. Atasha Jordan. She's a PGY1 at the University of Pennsylvania Perelman School of Medicine. She's also an entrepreneur and an avid blogger on her website, atashajordan.com. Welcome, Dr. Jordan.
Thanks. Excited to speak with everybody.
And Dr. Jordan, if I do have you correct, you have an MBA, correct?
Yeah, I got an MBA while also in medical school.
An MBA while in medical school. So for y'all who have questions about merging business and medicine, she'd be a great person to ask. And last but certainly not least, we have Dr. Somto Obi, who is a PGY1 at Baylor University College of Medicine. He's also one of the co-founders for the Melanin Doc nonprofit organization, which sheds light on Black physicians and medical students. Welcome, Dr. Obi.
Appreciate it, man. Thanks for having me, and I'm excited to present today.
Definitely. For y'all who don't know, Dr. Obi is also one of my personal mentors. He might not even know that, but I really look up to this guy, another UTMB alum, and I'm happy to see him here.
Appreciate it, Preston.
So right now, like I said, y'all, this is a Q&A. We're going to keep it going. We're going to keep it flowing. I want everybody to kind of give a little feel about how they got into psychiatry, where they did their training, and what they really like about the field. So we're going to start with Dr. Hairston.
Okay, I'm starting. All right, so I went to medical school at the real HU, Howard University College of Medicine, the only HU, and I did my residency at Howard as well, and I went to University of Maryland in Baltimore for my consultation liaison fellowship.
Awesome, wonderful, wonderful. So HU through and through. Okay, I love it.
Of course.
Next, we're going to move on to Dr. Donald Brown.
All right. I went to medical school at Wayne State University School of Medicine in Detroit, Michigan. I was fortunate to do my residency and fellowship training in adult psychiatry and general psychiatry, and forensic psychiatry fellowship at University of Southern California in Los Angeles. And currently, as you mentioned earlier, Preston, I'm doing my work still in Los Angeles. So, yeah, it's been great.
Thank you, Dr. Brown. I know a lot of people who are likely on this live right now probably don't know anything about forensic psychiatry, so I'm sure we can get some questions about that. And I'd love it if you can, inform us about that.
Okay.
Next up, we have Dr. Williams.
Hi. So like you said, I'm UTMB family. I went to the University of Texas Medical Branch in Galveston, and then I completed my adult residency at John Peter Smith Hospital in Fort Worth. It's a county hospital. If you've seen it in the student doctor panels, it's one of the busiest psychiatry programs in the country. I often had to remind myself that I was in psychiatry because I thought I was an internist at times. But I completed it there, and now I am back at UTMB doing my child and adolescent psychiatry fellowship, and it's nice to be home, back in H-Town.
Welcome home, Dr. Williams. Yeah, I'm from Southwest Houston, Texas, so I'm all about H-Town. I love the city, and all my H-Town people, say what's up in the chat. Welcome.
Yes.
Yeah, H-Town.
We have next Dr. Jordan.
Hey guys, so I am originally from the Caribbean. Shout out to all my Bajans and Trini folks in the audience. But I grew up in Pennsylvania, and I went to the University of Pennsylvania Perelman School of Medicine for medical school, and I also went to Wharton for business school. And I decided to stay in Philly because I absolutely love Philadelphia for my training, and I'm an intern right now in psychiatry at UPenn.
Awesome. And for those of you on the chat who might not know what intern versus PGY1 means, they're used interchangeably. That means they're in their first year of psychiatry residency training. And last, we have Dr. Obi.
Yeah, how you guys doing again? Like Dr. Williams and Preston, I'm also a UTMB grad. Went there for medical school. Got to embrace a lot of different specialties, and I chose psychiatry. Now that I'm at Baylor College of Medicine, as an intern, me and Dr. Jordan kind of been texting, so we kind of know how interning is. So I'll be probably able to answer some of the introductory level questions about psychiatry.
Awesome. We all know intern year ain't no joke. No matter what specialty you're in, intern year, it's an experience, it's a transition. So we're definitely going to get into that as well. So I guess just to start us off, I wanted to start us off with talking about psychiatry in general. Were all of you interested in psychiatry from the get-go, or did you have any type of special experience that pushed you towards that field?
Yeah, no, I was not at all interested in psychiatry at first. I think it's just honestly I didn't know enough about it to truly even like make an informed decision. But when I started med school, I thought I was going to be a surgeon, and now I'm like the exact opposite of a surgeon. But once I went through the medical school experience, what I realized, especially during clerkship year, was really just how important it was to talk to my patients throughout the day. Like honestly, even just today on the unit, like I had the opportunity to circle back and do afternoon rounds and just sit and chat with some of my patients. And this was on internal medicine, but it brought me so much joy. So when I think about my experiences so far in psychiatry, I think I just continue to be affirmed by the fact that I get the opportunity to really just get to know people's stories, understand the good and the bad that kind of bring people to where they are. As a first year in psychiatry, we're mostly seeing people in the inpatient units. So I really actually have the time to kind of sit down, chat with people. And even that part of the work just brings me a lot of just joy getting to know people throughout the day.
Yeah, so I can say that I definitely did not think that I was going into psychiatry. Coming into medical school, I thought I was going to go into internal medicine and work in infectious disease because I really wanted to work with HIV patients. Then in medical school, I had the experience of rotating on an addiction consult team and just a regular CL team, and I really learned about being at the intersection between psychiatry and medicine. So I actually still do now work in an HIV clinic. One day out of the week, but psychiatry was really what I wanted to do. I think the other panelists can also speak about how there's stigma about choosing psychiatry in medical school and in the Black community. So it was a tough decision, but I'm happy that that's definitely the specialty for me.
Yeah, so I can relate. I did not think I was going to be in psychiatry. I was determined and convinced that I was going to be an OB-GYN. In fact, I already had my letters uploaded to ERAS from the OB-GYN faculty. So I was just like about to just make the worst decision of my life, literally. But something reminded me constantly of the very fun times I had in my psychiatry rotation. And I just had kept having a thought, like, do I really want to go into something that I thought was going to be great? Or do I want to go into something I know was going to be great for me? So I just love psychiatry. In retrospect, I think about every single rotation. Oh my gosh, all the psych patients found me. Like, they found me. I would be on surgery and I had a psych patient and I was able to just have a very, very important moment with them that kind of changed the trajectory of their hospital stay. I would be on, some weird rotation, like a public health rotation, and then a psych patient would find me, or a psych employee, right, at the hospital would find me. And it just was always supposed to be a part of my story. So I love psychiatry. I love combating the stigma that Dr. Harrison mentioned. I mean, Black people, we just need to be better about accepting mental health. Health is important, and I love just advocating for mental health awareness and educating my community. So I would not change my decision for the world. I love psychiatry.
Well, we're glad to have you. Glad you made the right decision.
Yeah, just to echo what the other panelists said, 4 for 4. I also wasn't thinking about psychiatry when I chose it. I was actually thinking between cardiology and neurology. I always knew I wanted to be a doctor, something I had solidified in high school, had the grades, boom, I was ready to go to undergrad. I'm like, let's do this. And it's my wife in the background, everybody. And I attended Xavier University in Louisiana. And during that time, it was around Hurricane Katrina. So there was a lot of volunteering and aid with the relief effort that I had the ability to participate in. And during that time, it was something, during those experiences, I was able to find out more about myself and find out the relationships I was developing with those who I was serving. It was something that I thoroughly enjoyed doing. And my sister is actually a psychiatrist. She's 9 years older than me. She's a child and adolescent psychiatrist. And that was one of the main reasons I didn't want to do psychiatry. I wanted to blaze my own path. But through doing my volunteer work and also speaking with my sister, it was something that going into medical school, I kept an open mind about. And then, like everyone else was saying, during my psych rotation at Wayne State, it just solidified it. Everything else that I had planned was thrown to the wayside. And I'll just basically saying every day since then, this is me. This is what I want to do. This fits my mission as a doctor, wanting to serve others, wanting to help. And this is where I felt I could have the biggest impact, but also have the most variety as far as the day-to-day and just the greatest fulfillment that I could have in becoming a doctor was this field. And that's one of the best decisions I ever made in my life. So very fortunate.
That's amazing.
Yeah. Like what a lot of everybody was saying, for me personally, I came in thinking I was going to do something like a surgical specialty. And then, I was able to go and do my psychiatry rotation. I always kept an open mind. But really what did it for me was seeing some patients on the inpatient rotation, seeing psychotic patients. And it made me think back to one of my close friends who I know like through childhood. He later developed, some mental illness, some pretty severe mental illness. And knowing him before, he started developing some of that mental illness, I saw him as, we played sports together, played high school sports together, and seeing that transition from how he was, normal, typical, neurotypical child, and then, transitioning to living with mental illness. I could see, a lot of my patients with some of these issues when they're coming in, I could see them before. I could see how they were before, they had mental illness and then are later stigmatized. And then for other reasons where, in psychiatry, a lot of medicine is, black and white. We really are, figuring out how to treat patients creatively, through medication, therapy, different modalities. And I really like that option to, trying to personalize medicine for each patient. And then also being, able with like Dr. Was previously saying, just having the variety of having different type of practice. Some of the doctors here are academics, being able to work in a private setting, work in, have your own clinic, and then also being an inpatient, outpatient. So I really like that about the flexibility as well about the specialty.
That's awesome. I'm glad you brought that up because that's something that's really drawn me to the field as well. The flexibility and versatility that is available to you as a psychiatrist. You can really do a lot of different things. You can have your hands in a lot of different pots and still remain true to yourself and do the things that you love to do. And that's something that I want to continue doing when I'm a physician. So that's a great point. It seems like pretty much all of you were not coming into med school thinking psychiatry. However, based on your different experiences and your journeys, you all ended up in the same destination. And that just goes to show, that's how life works for a lot of med students like myself who may have came into med school thinking one thing and changed their minds. And a lot of people almost feel guilty about doing that, but you just have to let things be fluid and you have to let, life take you to where it's going to take you. One thing I want to talk about was the stigma behind psychiatry. I know historically, psychiatry has had a lot of stigma, both within the medical field and to people who are not in medicine. Can you all speak to that, and have you seen things change from when you first started to where you are now?
So definitely historically, I've actually written this is something that I love to research. If you go back to someone who considered a father of psychiatry, Benjamin Rush was actually owned slaves, and psychiatry was used to say that people who wanted to be free had mental illnesses, something called drapetomania. So psychiatry is something where we are not at the less than 3% or less than 4% of psychiatrists identify as Black. So there's definitely stigma within your own communities. Then there's stigma within just medicine, period. Like I see someone commenting about if your family members tell you that psychiatry is not real medicine, people are disappointed that you decide to go into psychiatry. I had a family member that was my mat day who said that she wished that I hadn't matched into psychiatry and why hadn't I gone into medicine. I have family members who tell people that I am a neurologist or a different type of psychiatrist, a different type of physician. So we definitely deal with a lot of stigma. I've got cardiologists who don't want to share their space in the ER with me. And I said, oh, do you want to go see that manic patient? Please, go ahead. Or are we both physicians? So it's something that you really have to deal with, but understand that we are going through the same medical school. We do the same type of work. We have to go through intern year with medicine. We have to pass the same step 1, step 3 to get our medical licenses. And me particularly in CL psychiatry, I actually spend the majority of my time outside of psychiatry on medicine floors, in the emergency room, in L&D, labor and delivery, in the ICU. That's where I actually spend a lot of my time. So people don't really know what psychiatry do and just the variety and flexibility of our specialty.
Yeah, I can relate to Dr. Hairston's story because, okay, so I was walking across the stage. Like I walked across the stage at the UTMB graduation. I had a lot of family there. This is the medical degree, MD graduation. Everybody who's getting a degree is a physician, is a doctor. I had a family member come up to me, after I walked across the stage, like, oh, what made you not want to be a doctor anymore? I see you went into psychiatry. And I'm like, psychiatrists are doctors. That's why you are at a doctor graduation. But medicine very much represents and echoes the stigma in the general population. Also socially, there are certain populations in society that don't get a lot of respect or don't get acknowledged. And that's what I feel psychiatrists have to deal with quite often. Just the other day, I saw some article, and it was like it had a breakdown of like the specialties, and it had psychiatrists and doctors. They were separate. So I'm just like, okay,
Wow.
so psychiatrists are doctors. Why is this even in the news? But you have to deal with that. You have to deal with it from other physicians as well. We don't get acknowledged, you know, like I'll be in the wards and they're like, oh, where's the medical doctor? Or even sometimes patients, colleagues. And I'm like, clearly my badge says MD. So there's a lot of stigma. And for me personally, I had to confront that upon deciding to commit to psychiatry. And I think that had a lot to do with my hesitance initially, because, you know, we work hard, right? We work hard for our degrees and we want to be acknowledged and recognized. But on the flip side of that, we can go ahead and confront this stigma and, you know, advocate to work against it and hopefully minimize it in our community. So it's definitely there. You'll also get called psychologist or therapist quite often. You know, a lot of us, especially in the Black community, they are not informed about the difference between psychiatry and psychology, or psychiatrists and psychologists. And I'm constantly educating, even among educated people, I'm educating the difference between, you know, a therapist and a psychiatrist. So it's there, you have to deal with it. But hopefully, as more people continue to be dedicated to this field, we can just promote more awareness and just combat the idea that psychiatrists aren't, you know, doctors, right? So,
yeah. And I think going off of that, there's the side of it where we as psychiatrists kind of experience some of the stigma, and we experience others not really seeing the work that we do on the same level as other MDs. But I think the stigma that exists within even the patient population really kind of permeates into the day-to-day of our existence as physicians. And I know so far some of the populations, whether it's based on racial or cultural, ethnic background, or even faith-based backgrounds, there's a lot of stigma that I see even with patients as they are addressing their own experiences. When I'm thinking about my faith personally, even in Christianity, and speaking with my patients who are of similar faith, I think one of the parts of stigma that stands out a lot is really being able to differentiate spiritual and psychological distress and separating that out from mental health. And a lot of that stigma, I think, continues to really inhibit and prohibit a lot of our patients from getting the full extent of the treatment that they deserve. But I think for me, that's one of the reasons why I have been drawn to the field and continue to just be that much more interested in really getting to understand the patient experience of stigma, whether that's from the healthcare system, from the general population, and then figuring out the ways that we can kind of work together as the patient-physician relationship, then also as a system to really help to educate, to help minimize some of that stigma that exists.
Yeah, just speaking on stigma just as a whole, echoing what everyone else has said previously, but just ways to combat it. Chats like this is something that getting the information out and letting everyone know that, yes, this is something that's very prevalent, even amongst each other, like they mentioned, our colleagues who aren't in psychiatry, but also even medical students. As an attending, I know day one, my lectures, I talk about psychiatry, I talk about history, and I focus on stigma. If you get nothing from this rotation, I'm going to end your stigma with psychiatry. And I want you to tell this to all of your colleagues and everyone else you know, family, friends, because that is the ultimate goal in medical school. That is something we should be pushing forward, because there's a lot of issues, there's a lot of medical conditions that are worsened by mental health, depression, anxiety, bipolar, schizophrenia. All these things can make other medical issues, when I say medical issues, diabetes, high blood pressure, things like that, they can make them worse if they're not addressed. So it's very important to kind of lower this stigma in order to not only tackle those issues, but tackle the underlying psychiatric issues. And it's our duty, especially when we go into our communities, to kind of enlighten and to kind of let them know that, you know, this is what it is and let's move forward. So I'm glad we're doing this.
Right. And I'm glad you brought that up, Dr. Brown, because I've been told the same thing, that there are a lot of other issues that are more important than mental health right now. I actually had a medical student tell me that, you know, I was talking about how I want to do a lot of global health work, and I want to increase the, you know, availability for mental health resources in Nigeria. And someone told me, why would people in Nigeria care about mental health when they're suffering from diabetes and poverty and high blood pressure and all these other things? So it just shows that mental health and, you know, psychiatric illness is still not considered as important as medical illnesses. So we really do need to reduce that stigma.
Yeah. Definitely.
Okay, so I see there's a lot of questions in the comments. I love that. Y'all, please keep putting your questions in the comments. We're going to do our best to get to all of them. So right now I have a question about intern year. Can you talk about the transition from medical school to intern year as a psychiatrist?
Yeah, I'm happy to start.
Yeah.
I think like being in it right now, one of the things I'm so happy about was the fact that I stayed at my medical school institution, because I think that just helped the transition to be a lot more seamless. I know overall the big jump of actually now having responsibility. I still remember like the first order that I put in and like no one having to co-sign it and how that felt. But then I think once kind of that joy and giddiness, I guess, maybe kind of like wears off pretty quickly once you're like in the trenches and working super long hours, day in and day out. I think it really is just a learning experience that has pushed me, I think, in a lot of ways to lean on others, whether those are like my co-residents, lean on friends who are out of my program, lean on friends who are not even in medicine at all. But when it comes to like the things that were most challenging for me, it really was really recognizing how to like manage a million things at once. And I think for me, the off-service months were definitely the ones where that came true most commonly. So for instance, like right now I'm doing internal medicine and really just being in that like quarterback position where you're calling all of the consults and doing the collateral and all the nurses go to you and everyone just goes to you for everything, and being able to learn how to juggle that with time. I think the biggest thing that I would recommend, even just to the fourth years who are going into residency in next year, is to be patient with yourself. Because I think I remember my first shift feeling so overwhelmed when I had a lot of that responsibility, but really leaning on the seniors, leaning on attendings for support, and being patient that over time you will get better. I know now this is like 10 months into intern year, and looking back to how I was when I started and how I'm doing now, it's such a marked difference. And I just feel like the growth has been amazing, but it took patience, it took time. So just keep that in mind, that you won't be like a rock star on day one. Maybe you'll be a rock star on day one. I was not like the perfect person on day one, but growth happened. And that to me has been a really great experience.
Yeah, pretty much echoing what Dr. Jordan was saying was, you know, intern year, that jump from being the person that's making the decision, that's putting in the orders, having the repercussions of, you know, the side effects are going to be because you order that medication. So you really want to look up to date and see what, you know, those drugs are, and not just because you're about to be pimped on it, you know. And for me, it was the biggest jump was being able to just like, you know, take it easy on yourself, because I started with medicine first. So I was an intern, you know, I'm doing psychiatry, you know, I wasn't reading up on, you know, the newest medicine journals like some of my co-residents when I got to medicine. So, you know, when I got there, I was nervous. I beat myself up many nights, just like saying, man, I should have done this better. I probably should have, you know, talked to this patient or looked this up, or I got pimped on this article. Just kind of beating yourself up, and you kind of get in this cycle of, you know, if you're not talking to people, if you're not talking to your co-residents, finding some support groups to just, you know, lean on. I have like a pretty good group from med school that we still chat and, you know, kind of dump what's been going on in that chat. So that was helpful. But I think beating up on yourself the first couple of months was the biggest thing for me, holding yourself up to all these expectations, because most of the people there, no matter what other institution they went to, no matter what training they had, you know, are going through the same thing. They don't know what they're doing either as well. So that was the biggest thing. So that really showed me you just need to ask for help, you know, get really cool with the nurses, you know, be very humble, you know, because the nurses, they, you know, they come in clutch for me every day, picking out my errors, you know. So just trying to be humble every day, putting in the work, and trying to, you know, not be too hard on yourself every day, because, you know, the next day is another day to try harder. So.
I love that. I love that, Dr. Obi. That is so important. I love that you highlighted support. That's one thing I was going to add, because I actually had a rough transition to intern year. So I did not get my first choice in psychiatry, and I saw somebody posted a question about the competitiveness of psychiatry. So psych got extremely competitive the year I graduated from my medical school. And I think there were about 25 to 30 around there, MS4s applying to psychiatry at the institution that I wanted to go to. And there was only like 6 spots. So of course, not all of us would get it. So I did not match at my first spot. So I had to move out of Houston, which I didn't want to do. I wanted to stay at home. So that was already a stressor. And then I went to a program, and though in retrospect I love the experience that I gained, I feel like I wasn't adequately I wasn't told exactly, the intensity of the program. So I went to a program that had a huge learning curve. I also started with internal medicine, and I mean, it was just a lot. I remember I worked on one of the busiest teams on the internal medicine service, and my attending was just brilliant, and he was always pimping me. And I just had to straight up tell him, like, look, I don't know, but I can get back to you. And I felt like he was kind of picking on me, but it made me feel so much better when my colleague, who was the internal medicine resident, said, look, I don't know either. Like we just both kept telling him we didn't know. And that was so supportive. So what really saved me that year, even though it was very, very difficult for me, was having a support system, right? Having family, having friends. I also value my faith. So I was able to find a church that just was huge for me. And then 2, getting cool with the nurses. Like I didn't realize how valuable that was, but I got cool with the nurses, and it just made my life so much easier. I think there's a lot of MS4s who graduate and get like that big head syndrome, like they're walking in the wards and they're the doctors now and can't nobody tell them anything. No, humility is so important. If you get cool with the nurses, they will help you, they will communicate with you, and they're like your number one advocates. So that was huge for me. But it was definitely a rough transition. So I would say, like everybody else says, give yourself grace, because you're not going to know everything, and neither is everybody else. Like you graduate from MS4. MS4, remind you, it's a real chill year, right? Most people have a real chill year, and then you graduate, and then it's like super intense. So everybody is just getting thrown out to the wolves. So just recognize that. Remember that you are not the only one who struggles. And then you're going to grow. Like that tension is going to help you become a better physician. So just keep that in mind. We all kind of struggle intern year, and I certainly did.
True. I can say that coming into being an intern was very scary. And my first rotation was emergency medicine. And you're used to in medical school being like, oh, I'm just a med student. Oh, let me ask the resident. But now I think my first patient my first patient was having an allergic reaction. The ED attending was like, what do you want to do? I was like, help me. I don't know. Help me. I don't know. I was like, a steroid. I don't know. Where's my book? Like you have to understand, like it's a big transition and it's a big change. It's a big transition and it's a big change for everyone. Now, some people are better at hiding it than others, and we also experience imposter syndrome. So just know what you know. If you don't know it, say you don't know it, but I'm going to get back to you. That was something that I had to learn a lot, especially on internal medicine. I was saying, I don't know, but the answer actually is just to say, I'm going to look that up, or I'm going to bring it back to you tomorrow. And if you want to impress your attendings, say, go home, look at it, read it, own it, and then bring it back to them tomorrow. Let them know that they didn't get you. You know this. You
That's good.
School. You're going to get it. You're going to get it.
That's good.
I love that. So I'm getting a lot of questions now about really the day-to-day work as psychiatrists in training. We have Alexandra Desir, who has a question. Says, I'm interested in child and adolescent psych and forensic psych. Those are 2 fellowships that are represented here on this panel. So can those of you who've done fellowships or are actively doing fellowships talk about exactly why you chose that fellowship and what your day-to-day looks like?
You want to go ahead, and Dr. Brown, you want to go first? Because I feel like I can. No? Okay. So yeah, I love child and adolescent psychiatry. One thing I didn't realize is that you're going to be spending a lot of time with the parents. And often the parents become my patients, and I have to shift the focus back on their child. I feel like a parent coach sometimes. I feel like a crisis interventionist. Sometimes I just feel like a just somebody who's just keeping the peace. But I really love it because what I'm finding is that I can really, really improve the dynamics of the home. And as everybody knows, the environment in childhood is just so important, right? You can't fix a kid in the office and then send them back to just chaotic environment. Otherwise, they're just going to end up back in a cycle throughout their whole lives. So I spend a lot of time with parents, but it's amazing. Also, my program offers a community opportunity to where they contract with one of the high schools. And that's really cool because we get to see patients in the high school. And I've never had that type of experience. And then also on inpatient, the teenage population is just very different than adults. You really get to bond with them. And I feel like being a little bit younger helps me with the child population. They always see me and they're like, how old are you? Or, who are you? And we can bond because I'm a little bit younger. And I know I'll lose that as I get older, but I love child and adolescent psychiatry.
Yeah.
I'm cracked. You're not going to.
And side note, the teens are really funny. That one time this has happened to me several times. Teens will tell me, look, Dr. Williams, you're not going to come up in here without any mascara. You're not going to come in here without any lipstick. I mean, they make sure I'm put together. So that's really different than my adult population. I wasn't ready for that in the teen population.
Yeah. So for forensic psychiatry, it's a 1-year fellowship that you can complete after residency. Residency is 4 years, a general psychiatry residency. And I was able to just transition over from my general psychiatry residency to a forensic fellowship at the same institution at USC. So the fellowship, basically the way it's broken down, specifically at USC, about half of the time to about 60% of the time, it's more lectures. So we're learning everything that goes into the law and mental health, the history, important Supreme Court cases, and then any type of experience that you as a psychiatrist would have in the courtroom. So basically what I do on the day-to-day is mostly when anytime a lawyer or a client has any question related to mental health and something in the law, whether it be something criminal or whether it be something civil where money's involved, then I would be come on and I would do evaluations, or I would answer any kind of questions that can be used, and I can write reports or I can testify in court on those questions to kind of break it down for those people in the courtroom who don't know what schizophrenia is or know specific criteria with the law. So basically, I'm like an expert witness when going into court. So that 1-year fellowship, you get experience with lectures. You also get experience by doing these reports. So you get supervised by a faculty advisor, and you're doing these reports that you would be doing on your own. And also we got training in local jail, specifically Twin Towers Correctional Facility, which is actually one of the nation's largest inpatient psych hospitals, but it's a jail. So that just lets you know as far as mental health and the law and us as Americans, how we treat the mentally ill in our society. So a lot of that is what I do day to day. Full time, I work as an inpatient psychiatrist 4 days a week, and then 1 day a week I have private forensic psychiatry practice. So I've been doing that for about the past 1.5 years, where I would be going into the local jails, answering these questions for lawyers and writing reports or testifying on those reports. So it's something that I use to supplement my full-time job, and something I love about psychiatry, the variety. And I can choose to take which cases I want to do. Last week, I chose not to take any cases. Tomorrow, which is my forensic day, I'm doing 3 cases. So I like the variety, and it's something you see, something new every single day. And I only learned about forensics at the end of medical school. And then I went to a psychiatry residency who actually stressed forensics. So I actually got to testify as an intern and as a second year at my program. So I got that experience in the courtroom. And a lot of my attendings were actually the attendings in the fellowship program. So you get that experience. So if that's something you're interested in, I will look in residencies that have that program available as a fellowship where you can get that exposure in medical school or in residency.
That's awesome. And Dr. Harrison, I believe you're also consult liaison trained?
Yes, so I am a CL or consultation liaison psychiatrist, and actually I spend most of my days seeing patients who are on other services and in the emergency room. So today I was in the ICU evaluating patients who had dementia, patients who had TBIs, who have different behavioral and psychiatric manifestations. So I really look at the interface between what medical conditions cause psychiatric manifestations and symptoms, like what medical conditions lead to someone being psychotic, or what medical conditions can lead to depression, like hypothyroidism. So I really look at the medicine, I look at labs, all those things. So someone asked in the chat about really, do I feel like CL is a good interface or a good connection between physical and mental, even though they're all the same health? And yes, definitely. I don't have what people think of as a psychiatrist. Like, I have a couch at home, but I don't have a couch in my office. I don't have outpatient office. I work in the emergency room. When I do see patients, it is in the HIV clinic because I do a lot of collaborative care. So I think that many people don't know just the variety of things that you can do with psychiatry. In addition to doing consults for other specialties, I consult for corporations, for companies. I do consults, wellness and psych consults for Google, for YouTube. So, you know, psychiatrists can do anything, and you just really have to find your niche and optimize that.
Okay, Google. All right, YouTube. All right, I see it. See, versatility. That's what we're talking about. Psychiatry gives you versatility. It gives you flexibility. You can do all the things you want to do as well as practice medicine. And I think that's a perfect segue, because we also have a lot of people in the chat asking about, as a psychiatrist, don't you ever get tired? Do you ever miss practicing the other side of medicine? Do you miss the physical exams, or do you miss things that people think you don't do as a psychiatrist?
I'll let others answer that, because I still do the physical things.
Right.
Yeah, I still do it. I mean, I do inpatient psychiatry. So anytime we have an admission, I'm definitely doing physical exam. Anytime something new comes up day to day. And when I say inpatient psychiatry, I work in the state hospital levels. So generally on average, the length of stay can be anywhere from a few weeks to a few months. So I'm seeing patients throughout this duration of time. So if anything new does pop up, I'm the one doing the physical exam. I'm the one prescribing the medications and doing all those things. So those things don't go away. And if you choose to go into psychiatry, please keep up to date on those things, because even though we don't do it as often as maybe some of our other counterparts, we still do those things. So that's a big misconception.
Yeah. And I think additionally, I think it's important to remember that although like the threshold for admission to a psychiatry unit tends to mean that most of our patients medically are relatively stable, there are still emergencies that happen on the units. And I think that, for instance, things that I've had to deal with, whether it's falls, seizures, syncope, one of my patients had an MI on the unit, and this was on the psych unit. So still having to be on top of the medical things, remembering that as a psychiatrist, you're a doctor, and that you often will be that first call of response for some of those emergencies. And yes, a rapid might be called and you might get support eventually, but you want to make sure that you kind of know the ABCs of the initial response to some of these more acute issues that might arise. So definitely wanting to make sure that you keep on top of whether it's your ACLS, your BLS going forward. But I found it super useful to be able to just keep on top of all of that and been able to like help a lot of my patients in some of these crises that have happened.
Yeah, I'd like to just add too. I also still do a lot of physical exams. I haven't done it too much in child and adolescent psychiatry, but I have a moonlighting position in which I am the attending physician of a whole unit of about 60 patients on weekends. And lots of things can happen in the inpatient unit. So this is good, right? Because you've heard from 4 psychiatrists who told you that they still do physical exams. So we're combating ideas that are just false. We are doctors. We do things. We have to be prepared. And we still maintain our medical education and practices. At JPS, I felt like I was a family medicine physician and just had a lot of psych patients. I started a lot of medications for diabetes, hypertension. I did so much preventative care on the units, because the thing about super sick psychotic patients, they are not taking care of their health. They are not going to their primary care doctors, right? They are getting taken off of the streets by police. Those are the type of patients that I took care of at JPS. A lot of my patients were very, very, very low socioeconomic status patients. They were homeless. I mean, I could drive out of the hospital parking lot and see my patients holding a sign asking for money. In those type of populations, it is just essential that we do act as the preventative care and family medicine doctor, because we're the only doctors that they see. So absolutely, people ask me all the time, oh, do you miss being a real doctor? And I'm like, you don't even know what I do. Like I literally am out here treating diabetes and hypertension and hypothyroidism. I'm literally like getting making people have so much of a better quality of life because they're not making it to the clinic like more privileged patients. So I just love that somebody asked that question, because as you can see, most of us still do a lot of the things that we learned in medical school.
Definitely. And I just want to add that you always have to be ready. For example, right now we're in the COVID-19 crisis, and my residents from years 1, 2, 3, and 4 have been deployed back to the internal medicine service to help their colleagues. So you have to be ready at all times. You never know when there's going to be a medical emergency on your floor or in your office. These medications that we give patients, you can have someone who has a dystonic reaction, who has different reactions to these medications, someone who has an allergic reaction in your office, someone who has a hypertensive urgency because they are paranoid and they don't want to go see their primary care physician. You are their primary care physician. I've had to write anti-hypertensive for patients who are psychotic and will not go see another doctor. So after I collaborate with other physicians, that's what I have to do. So we have to always be ready. Psychiatry is never a dull day. You have to stay ready so you don't have to get ready. Honestly, psychiatry is tough. It's medicine, it's mental health, it's policy, it's advocating for your patients.
Yes, that's all very true. And I'm glad you all are dispelling those myths. See, that's a great question, because people think you can throw your stethoscope away as soon as you start psychiatry residency. And that is not the case at all. So I'm proud to know that you all still have kept your physical exam skills sharp. You know, you guys are still doing all the aspects of what it means to be a physician. And that's what we need to continue to do. But one of my favorite things about this series that we're doing is the mentorship aspect. It's not every day you can get 5 psychiatrists together, 5 Black amazing psychiatrists, and really pick their brains about their experience and how you can be in their shoes in the future. So I see a lot of questions for students like me who know they want to do psychiatry, who are applying soon. What should they do to be competitive? What do you think you should do as a psychiatry applicant to stand out?
We don't let the residency director.
We're all looking at the program director.
Go ahead, director.
Okay. Let's see. Dr. Obi, how about you start?
Okay. I think with me and you, we always tap in, make sure we know what's up and what's happening. So you know what's coming up down the pipeline. I think the best thing anybody can do is just make sure like a lot of you on here, a lot of these other doctors here today, they have Instagram pages, they have social media, they have blogs, they do vlogs, program directors, attendings, tap into those networks. This is a great time. You have technology. You can connect to any doctor you want, really, with your fingertips. A lot of people are putting out information that was usually, passed along in dorm rooms, in private, fraternities and groups. But now you can tap into all that information on, social media, on people blogging about their lives and their stories. And so I think this is like a great time to, do any specialty, especially psychiatry, because, we're here right now talking about it. And then to make yourself more of a good candidate, I think, like what Dr. Williams was saying, it's become a little bit more competitive every year, just because people are, learning more about the field and what other options they have. So making sure you have a CV that points towards you wanting to do psychiatry, having mentorship, having the basic things like community service, but joining interest groups. And what I realized is the more you kind of network and talk to people, they'll call you, they'll be the first one to hit you up, they'll talk to you about what's new. They'll send you information about what's breaking out in the field. So just kind of getting a network and tapping into them routinely to see what opportunities out there can never hurt, I think.
I agree.
I was actually just going to ask if someone can quickly just summarize the question real quick, because I can't hear Preston's audio very well.
Oh, they wanted to know how to become a competitive applicant. What should you do to make yourself competitive for residency? And how has mentorship then how has mentorship helped you in your program?
Okay.
Now I'm the host, Preston.
Well, now Jordan. Yeah.
From my perspective, when I was at USC for 2 years, I was actually the coordinator for incoming residents who want to apply to our program. So I was the one that coordinated all the dinners and made sure all the applicants who were coming in kind of knew their way around. So something my program was basically looking for, we were looking for diversity. So we were looking for minority candidates. We were looking for people who, basically look like the population we serve, which is predominantly Hispanic, African-American, and some white patients. So if you are going to a program like that, make sure you do research to see, first of all, see what type of patient population that residency program is serving. Because chances are they might be looking for someone who looks like them, because it will be helpful. When you do get the interview, it's very important to sell yourself. Be yourself. If you're a person who's an introvert, it's okay. If you're a person that's outgoing, that's also okay. But just make sure that they're trying to see that you fit their program. So when you do go to these dinners and when you do go to these interviews, basically they're trying to sell their program to you. So it's your time to shine. So make sure you put everything on your CV, curriculum vitae, your resume. I put stuff on there from college. I put stuff on there from high school. I mean, what are they going to tell me? Shorten your CV? Like, no. And some of my interviews, they brought up that stuff from high school when I did volunteering in New Orleans, when I volunteered in Detroit. So they'll talk about those experiences. So it doesn't hurt to sell yourself. That will make you more competitive. That will show you are a well-rounded person, not just in that specialty you're going to, because they're going to teach you the tools of the trade in psychiatry. That's why you're going there. But they also want to see that you have a life outside of psychiatry too, and that you'll be able to thrive in this type of environment with the co-residents that you'll be working with. So once you get in there, sell yourself.
One thing I want to touch on is the point about mentorship, and really kind of spend time to emphasize how important mentorship can be, but then also to separate it from sponsorship. So I found both of those to be just so incredibly important in my experience as a medical student, now as a resident. So mentorship, thinking of that from the standpoint of finding someone who can help guide you along the path. So that can be someone just one step above you, whether you're MS4 looking at an intern, you're MS1 looking at an MS2, just finding someone who can help guide you along the path because they've been there already. Then there's sponsorship, and sponsorship, really thinking of someone who can advocate for you, who can speak on your behalf when there are opportunities that arise, and really put your name in the hat for some of those opportunities. And I've just found time and time again in my experience of really connecting and investing the time to get to know people, doing it more so than just this transactional, what can this person do for you, but really building up the relationship of getting to know each other. How can you as a mentee or someone being sponsored be helpful, be on a project, do something to be of help and service to the person who's also feeding into you. And I found that really being able to take the time to focus on my role as a mentee and then also my role as a mentor, and really just building relationships with people who can be in positions of power to sponsor me and advocate on my behalf. I've had a lot of great opportunities arise because of that, and really want to just encourage you, even if you're interested in psychiatry, your mentor or sponsor does not have to be in psychiatry. I have mentors and sponsors in plastic surgery and neurology, people who are just bosses and can make boss moves and will bring me along the way. One instance here, Dr. Hairston put my name in the hat to even be on this panel, and just to have those types of people who have your back and will be willing to support you. Because whatever it is we're doing, we can't do it on our own. And just wanted to remind you guys to lean into the people who can help get you where you want to be.
I love that.
I can give the last as the program director,
of course,
about what we're looking for and what's important. So I see a lot of questions over here about how do you show your interest in psychiatry. So the way that you're going to show me your interest in psychiatry is that you actually do something that involves psychiatry. You're interested in the student interest group, or you are doing some type of community outreach that includes mental health. Find something, or you tell me that you volunteered with NAMI or that you did some health screenings. I tell interested third years who haven't rotated yet or second years, come and be on call with us. Like, do a call with us. Do a Saturday morning call with us. Do a Sunday call with us, so that actually we see you. We know that you're interested. If you're really able to do in a way. I know it's tough right now, but always do put you on people's radar. Also, there are tons of, and I send this out a lot because I'm also the president of the APA Black Caucus. I send out a lot. We send out with each other a lot of opportunities for paid clerkships or rotations for minorities interested in psychiatry. They're all around. Pay attention to that. Go to those, because medicine is a small world and Black and brown medicine is even smaller. So it's really about networking. Like, if I'm like, oh yeah, I know that that's my friend's mentee, let me make sure that someone interviews them. Let me talk about it, because it's a small world and we all sit at the same tables and we talk about you guys. We talk about who left the interview and didn't go to the dinner or didn't go to the lunch with the residents. We talk about things like that. Like, if you're not able to show your interest for long enough, like, why should you be ranked? So it's really about, you have to take the time to be proactive. Show yourself. This is a time where you have to let people know. And now I'm talking because I'm in my house, but I'm a pretty introverted person. So if you see me around, I probably have on my headphones, but I had to step up my game and I had to say, hello, I just wanted to make sure that you saw my CS score or my CK score, because I struggled with step 1. You have to put yourself out there. And I wouldn't be where I am without my mentors, because people talk and people know each other. So Don't be afraid to ask someone, like, can you be my mentor? Or can you help me? Or do you know someone who I could talk to? Especially if you're connected to HU. We have a big network. Make sure you reach out. And SNMA as well.
Yes, shout out SNMA. Shout out APA Black Caucus.
Can I add something onto that?
Yes.
Just because I didn't realize how important this is until I became a resident. Talking about trying to get into a residency programs, please realize that the residents have a pretty significant voice. So that means if you are rotating with the residents, you have to be on your best behavior. They will speak to the attendings and let them know if they like you or if they do not like you. So if you're interested in psychiatry, especially at the institution that you're at, I definitely would recommend that you go above and beyond and do things that, separate you from the other applicants or the other MS3s. So staying later, or saying, you know what, I'm going to do the whole interview, or saying, hey, Dr. Williams, can you tell me more about this? Or do you need any help with this? Because that really makes a difference, especially at my adult program. I started noticing that the ones who matched were the ones who got in really good with the residents. And actually, the residents had a very big voice in the match process. So I just want to make sure you guys know that a lot of times the residents are the ones you want to go ahead and show yourself approved to, for sure. Because the attendings, they're busy. Yes, they'll be there. They'll acknowledge you. They'll see what you're doing, but spend the times with the residents, because they're going to communicate with the attendings.
I love that. Dr. Hairston, we're going to go back to you as the program director in the virtual room. I see a couple questions. One from Joyce, who's talking about IMGs, or who want to go into psychiatry. What should they do to, propel them forward in the application process? I know sometimes IMGs or people who go to school outside of America and the Caribbean have a tougher time. So what can they do?
So for IMGs, I'm going to say that you really need to, again, make sure that you are visible. So if there are conferences, whether it's the APA, whether it's the BPA, whether it's ACAP or Apple for forensics, whatever it is, try to go. Usually it's free. Usually it's free for medical students. So go there. And if you see someone who happens to look like you, that would be a time like you should be like, oh, hello, Dr. Jordan. Brown face in the room, black face, hello. Do you know someone who can help me? Or do you know how I could talk to someone? I think that it's difficult, but you really have to go to these things, because otherwise you're in a silo, you're alone. I have lots of medical students and even residents who've told me, like, I've never seen a Black psychiatrist. I've never seen a Black female psychiatrist. I don't even have a Black physician at my institution. So when you see people reach out, now do all of your mentors have to be Black or brown? No, they don't. I have a mentor. Most of mine are, including Alpha Stewart. So I come through the greatness. But one of my mentors is a white Jewish man who was my fellowship director. And even now to this day, okay, I only finished fellowship a couple years ago, but now he will say like, "Oh, Danielle, can you talk? Because I have this opportunity. Danielle, can we write about this? Danielle, do you know any minority students that can come over to my program? Because now I'm a chair." So reach out, make yourself visible. Also, I mean, in these things, they're free. Like, just do it. If you're able to, just go. Also, I just wanted to say quickly, because one of my mentees over here, Annie, reminded me that for the Black Caucus, I'm going to be having the first ever APA Black Caucus Diversity Residency Fair. And that's where it's going to be 2 parts. And the first one is going to be on May 15th from 3 to 6 p.m. This is intentionally inclusive for this group, for SNMA, for Black and brown ethnic minorities to meet these programs. And I am I sit on these panels, I sit with these program directors who say, "I don't know anything about diversity, Dr. Hairston. How can I find Black students? Like, what are you talking about?" So make sure that you sign up and you attend. This is something that I'm doing in my presidency. The APA didn't happen, so we're going to bring it to your screens. We're going to make sure your face is there for these programs so they can't feign ignorance and say, "Oh, I never have anyone to interview who's diverse. I don't know how my program is all white." Like, come on.
I love that. I love that. You see, we're creating opportunities for our community. We're plugging us into those spaces. And that's what I love about this, the SNMA Sowing Seed Specialty Series. This is what it's about, to create those spaces and to let people know that you can do this. You can really put yourself out there and create the dream that you want for yourself. Now I got a personal question, you see, and I'm the host, I'm the moderator, so I can ask a personal question. Now this one I'm going to direct to Dr. Brown and Dr. Obi. As Black men in psychiatry, now we all know Black men are underrepresented in general, in medicine in general, but in psychiatry especially. I just want you all to talk about your experience, how it's been so far, and Dr. Brown, especially with you working in the prisons. I'm sure you see a lot of Black men on a daily. They're in the system and have been cheated by the systems. So, how does that affect you, and what do you do to combat that?
Yeah, great question, Preston. So actually during my fellowship, I actually talked about this topic. I did a research project and presented at JAPL, the journal related to forensic psychiatry, but also all forensics. And my topic focused on racial trauma. So it's something that a lot of doctors, but specifically forensic professionals, don't talk about. So with individuals who are in certain situations that are alleged of committing crimes, a lot of times when they do go to jail, they're automatically stigmatized and they're like deemed, "Oh, this person was psychotic," or "This person had aggression issues," or "This person's paranoid." But as doctors, we don't do the background. We don't do the cultural competency training to understand that, hey, maybe they were in an environment where there's a pervasive distrust of the law for just reasons. Maybe they had a significant other or themselves were put in an unjust situation, which could seem like paranoia, but it's not. So it's a lot of education of people that I see, of my clients that I see, the lawyers I speak to, and even my fellow forensic psychiatrists to know, like, hey, this is something that's happening in our community. And even when I presented it to my program, they were enlightened. Like, a lot of them didn't even know about this topic. So it's very important when you're in this specialty, especially when there's so very few of us. I think it's me and maybe 2 other Black male psychiatrists in Southern California altogether. And the other one is like in his 60s. So it's very unfortunate. And it's good because I'm getting a lot more clients who look like me, who I'm able to evaluate and use this lens to basically evaluate them, to say, hey, don't prescribe this medication. This is something normal based on so and so and so and so. So it's less stigma and it's less intervention that isn't needed for that person, but also the education part of it. And it's something I enjoy doing, and it's something we need a lot more help with, not just here, but all over the world, essentially. The stigma is real. Just as a Black male, speaking to that, just in psychiatry, there's not a lot of us there either. But what I found, what helps me is basically the number one thing in psychiatry is developing the therapeutic alliance. If you don't have that, you're not going to get adherence to treatment. You're not going to get your patient to open up about what's really going on. And you got to go work through a lot of defenses to eventually get to that, which could take time. So if you're able to develop that earlier and more effectively, then you can help your patient in a more full manner. So with me and my background, I'm a person, how I'm talking to you is how I talk to my patient. I try not to use a lot of jargon. I try to, go where they go as far as in the interview and kind of talk how they talk. And a lot of times you get that person opening up to you more. So a person that looks like me, people in our community, I feel like I have that connection with. And it's something that we definitely need in psychiatry. It's something that we have to push for. And that's been my personal experience.
Okay. And Dr. Obi, do you have anything to add?
Yeah, I mean, I'm just gonna pretty much echo a lot of what Dr. Brown was saying. I think being a minority in medicine, there's a stigma with that, and then being in psychiatry is even more so. At least my personal perspective about everything is that, there's been a lot of support, with staff, seeing a Black doctor, but, also, difficulties of, your background, how you interact with the patient, and what's the social norms and, specific hospitals and different environments has been interesting. But at least for the patient-wise, dealing with, we deal with patients with perceptions and delusions, and it's very easy, for like a patient that is paranoid to be, especially the Black male or Black person in general, to be, labeled as just straight paranoia. But, a lot of what we see in the field is like a lot of these issues will stem from, the pervasiveness of the issues will stem from real scenarios and real things that have happened. So I think at least for us in minorities are able to dig in deeper and to like differentiate, is this paranoia or is this person really, threatened because he's a Black person or Black male? And I mean, everybody in this chat right now knows how it is to be an African American in America, talk less in the medical field. So, they understand that we do all have some slight paranoia in everything that we do. So, and a lot of that is real, But, it's also been a good, opportunity because I think we shed so much light on issues that need to be brought up to the forefront. We bring up so many issues that other than mainstream society won't know, white America won't know or don't understand. And just like a lot of the studies have said, the lack of diversity is killing patients. So, I think it's just a plus to see more minorities going to psychiatry, to go into medicine, and I'm here for it,
Thank you. Like, that's great to hear. As a Black man going into psychiatry, a future psychiatrist myself, I'm glad to know that, there's a camaraderie out there. There's a team that I'm going to be joining once I enter your ranks, which will be, God willing, very soon. So I know like the comments are still going crazy. I just want to make sure I'm respectful of everyone's time. Are y'all up for another maybe 5 to 10 minutes of questions? Is that okay? Can we keep rocking? Okay.
Keep it moving.
So this question I'm going to direct to Doctors Jordan and Williams. I saw a question from Mariel Galvan that I thought was amazing. It's about avoiding burnout in psychiatry. I know for me, one of the reasons I was kind of going back and forth on it in the beginning was I didn't know if I could handle all of the emotional toll that being a psychiatrist may take on you. So how do you manage compassion fatigue as a psychiatrist? And what do you do to combat burnout?
So I was actually thinking of this as an answer to somebody's question that asked, what would be some things to note as far as somebody wanting to go or would be a good fit for psychiatry. And I was thinking, well, if you could manage a lot of heaviness, you'd be great for psychiatry. So for me, I recognized very early on that there's only certain things that I take home. I see a lot. I've seen a lot with my patients, a lot of traumatic things. But when I leave the hospital, most of the times I turn it off. I'm not thinking about it. I'm not going home, can't sleep at night because of what happened to my patients. And that's something that I'm so thankful for, because if you do that, I think you will be very burnt out very quickly. But I still make sure my cup is full. I still make sure that I do things that are very well-rounded and making sure I'm well taken care of. So I have my support system. I have my family. That's my biggest support system. I have my faith. I probably should have said that was my biggest support system, like the Lord. So Lord, forgive me. You were the first one. So I have the Lord, I have my faith, and then I have my family and my friends. And then I also have my self-care regimen. I probably, this quarantine messed me up, but I get massages like once a week. I leave work on Fridays and I get my massage. Friday afternoons are dedicated to me. My son stays at daycare. My husband is at work, and I am just taking care of me. I'm just pouring everything that I may have accumulated that week in my cup out, negativity wise. So I just encourage you to if you're going into psychiatry, make sure you have a very good regimen that consists of self-care and support, because you will see things that are just devastating. If you have a heart, like most of us do, because we're interested in psychiatry, you will, occasionally be like, man, that's so sad. Like, what is life about? Like, why would the Lord allow this? But you have to go back to, what you have to go back to taking care of yourself and remember what you're there for, just doing the best you can with what you have. So I would say those are the biggest things: my faith, my family, and my bomb self-care regimen. I take care of myself. I get my nails done. I get a massage. I get quiet time, and I know when to say no. That's another thing I think a lot of people in general need to know how to do. When you're a resident, it's going to be busy. A lot of psychiatry residency are busy. You need to learn now while you're in medical school how to say no. Can you do this for me? No. Can you do this? No, because I need my rest. I've been working all week. I need my rest. So learning to say no, I would say that's number 4.
I agree with all of those. And I think some other things I would add when it comes to the compassion fatigue, because I think honestly, so far in residency, some of my rotations have caused me to have some compassion fatigue. As Dr. Williams was saying, a lot of us have this heart for our patients, and I've been learning in this first year how to deal with that. And in addition to all the things she mentioned, I agree: family, faith, support, self-care, all of that. But I think with my residency program as well, some important questions to ask when you're on the interview trail is really, how does your program support its residents? And for me, so I'm at Penn, and I just absolutely love my program. I think from a person standpoint, we have process group with the co-residents that happens about once a month, and really having the opportunity to lean on my co-residents and discuss our shared experiences and learn how they've handled different difficult situations and kind of work through with advisors who help us through that. That's been incredibly helpful for me. And then I think as well, something that a lot of programs encourage is joining or starting in therapy if you're not in therapy already. And that's something that for me has really helped to change a lot of my experience in residency so far. I started therapy just about the midway point of intern year, and it really has made a big difference. So I think thinking about whether or not the programs you're applying to even allow the time to go to therapy, because sometimes that can take out of clinical time, and my program is very supportive. They recognize the importance of therapy and they allow us the opportunity to do that. So I think those are some of the things you can also think about. Yes, there are things you can do on your own to help support your own well-being in the midst of taking care of patients, but then thinking about how does your program support you through that too.
Just to kind of really quickly back up what Dr. Jordan is saying, that isn't a big priority. At least that's something when I came into residency, realizing. So I went across the country. I didn't have that support there in place. I had it back home, but it is important to seek that out and establish it very early on, because once you get down the road of dealing with stress in a negative way, it's hard to get off that road. When I say negative way, partying, drinking, doing what other things that a lot of doctors and a lot of professionals, when they're in high stress environments, can tend to go towards. So you really want to develop everything that Dr. Williams and Dr. Jordan was saying early on, and making sure that, stressing that importance. So I just want to add that.
And also going to therapy yourself.
Yeah.
I think that, my family and friends who know, like, I go to therapy. That's why I thought I was going to be late for this panel, but it doesn't matter. I go to therapy. No one can shake that. Like, that's what I'm going to do on Wednesdays at 6 o'clock. Okay. I don't care if I have a note to finish, if I have something, I'm not scheduling anything during that time. And also what's really important is to remember yourself outside of psychiatry, remember yourself outside of medicine. So my team, my family, like my network, my friends, my boyfriend, my therapist, like they keep me together. Like this corona time, like just having to do consults in the ICU, it's scary. But my friends, my family, my sisters will send me memes, like have me laughing all day. We watch 90 Day Fiance. I don't care. We watch it all together. We have watch parties. We do the things that I like to do outside of medicine. You got to remember who you are, and you have to keep that as your identity, even though you're going through medicine, even though you're going through psychiatry, even though you're seeing suicides, even though you're seeing overdoses, addiction. It's a lot. You have to remember who you are. Like if you know you like Tiger King, like I do, okay, you know what? You have your Tiger King time and you watch that. You go to therapy. You remember who you are outside of this. So that's how I do it, and that's what I encourage you guys to do as well.
I love that you brought that up because I know among medical students, there's this like unspoken rule that if you go to therapy, you go to counseling, that's going to negatively impact you when it's time to apply to residency, that they're going to turn around and tell, the schools that you apply to that, this person is going to therapy, this person's seeing a counselor, and they're afraid of how that's going to impact them. Can you speak to that, if that's a real thing at all, just to dispel that rumor?
So there are, I think, and the ones of us who are attending can keep it real. Like we do know that when we fill out applications, they do ask you, do you have a medical condition, or it might say a psychiatric condition or anything like that that can keep you from doing your work? And actually, no, I don't. It's not keeping me from doing my work because I get going to treatment. I have a therapist, I take medication or whatever it is. So you can answer that question honestly when you're applying for your licenses, for your jobs, for residency or whatever. And residency should not be asking you that.
Right.
So, so it is something that remains a stigma even on your licensing. But if you're getting treatment, you are telling the truth, right? You don't have any condition that's going to hinder your practice and your treatment, right? Because you're in treatment and you're taking care of it. So you're answering honestly.
Awesome. I love that. Thank you. So for all y'all out there who have the same thoughts as me, the same question, there you go. If it's not keeping you from doing your job effectively, then there's nothing to worry about, and continue to get the help you need. Continue to have that outlet. So I think we have time for 2 more questions. Really, we only got time for 1, but I'm gonna push it to 2. So it's all good. So we got time for 2. Now, this one comes from Sean. This one is about advice for medical students. So like, for example, I'm a medical student. I'm applying this year. I have social media. I have a social media presence. On the one hand, we're getting told that it's good to have a social media presence because programs like to see that you're, active and involved. And on the other hand, it might be bad if you have, some unsavory things on there because who knows what they can see, and that might affect you in the future. So once again, Dr. Hairston, the program director in the room, I'm leaning on you on this one. What do you feel about medical students having social media as well as discretion?
Okay, I'm probably the worst of all the program directors in the country. Like I said, I'm the youngest one and the most black one that there is. So, and I did the Don't Rush challenge. You saw us on there,
and we love that, by the way.
Thanks. That's my team over there. So I think there are ways, and Obi can tell you, like, I think there are ways to effectively use social media. So I think Shun asked a good question. So I have my professional social media, my professional one that I just made, because I felt like there is a way that I really need to reach out and I really need to connect with the residents, with Black medical students, being in the leadership position I'm in. But you guys don't see my my other Instagram where I do the Savage Challenge. Okay, I didn't do that. but you don't see that one, but I can keep it separate. So either separate it, but I think it's important that you don't lose what value, like what Dr. Williams, what Dr. Jordan have. And if you also know one of my best friends, Dr. Jordan on Twitter, Atasha Jordan. So there are ways to use social media effectively. So if you have a platform, it's good, but you might need to make a separate one. You might need to have a separate one, or you might really need to monitor what you're doing. If I happen to look at you on social media, listen, I look at my patients on social media because sometimes they're manic and they're threatening people, and I just want to see what's happening. I don't want to see anything like, you don't want to see substance use. You don't want to see anything like that that's inappropriate. So really just try to be mindful of what you're posting. Also, just one more thing, I'm going to be launching a Black Psychiatry Instagram on Friday. That's why I'm like the most social media program director that probably should be answering these questions, because I'm all for social media, because that's how our community remains connected and networks. So we really need it. But if you are a Black medical student who's interested in psychiatry and would like to be featured at Black Psychiatry, just follow that. We're coming out, all of us are coming out on, even if you didn't know, we're coming out on Friday. We're rolling it out.
There you go. Follow Black Psychiatry.
I think
on Instagram.
To the social media question as well, especially from a resident experience, and having kind of working on growing my social media presence and with my blog as well, I really just want to emphasize the importance of remembering that the things you post, if you have a public account, this stuff is public. And as someone who's pretty active on med Twitter, on psych Twitter, and on Instagram as well, I have seen people have downfalls, people who are residents. I've seen attendings have downfalls based on the things that they have posted. And something I saw that it was like a mnemonic that I found very helpful to help you to think about what you post on social media. And it was like literally a mnemonic think. So the T was, is it true? H, is it helpful? I, is it insightful? N, is it necessary? K, is it kind? And basically, like, if it passes that test, then it probably is okay. But I think the necessary part of it is probably the part that when I am posting anything on social media, I think about a lot of, is this content necessary? And then the helpful part, because there's a lot of things that people post just for the sake of it. If you're posting for clout, you're posting to try to get your follower count up. And at the end of the day, remembering that you are a medical professional, you're entering into a profession where in many ways, from professionalism standpoints, we're held to a higher standard. So just keeping that in mind. And when it comes to, especially as a resident, I've had conversations where recognizing that your job, what you're doing as a resident is still a job and you can still be fired. So don't forget that part. You might not get kicked out of med school, but you can truly lose a job. So just be mindful as you're growing your social media presence, what you look like and what it makes your institution look like as well.
True. Great words of advice, great words of wisdom. All right, y'all. Comments still going crazy, but I said we only had 2 questions. We have one more question left. This is the last question. This one is coming from Tay Mikimoto. She says it's a bit off topic. That's okay, Tay. I've been off topic too, but we moving. I heard it's tougher for female psychiatrists to find love. Is there any truth to that? Definitely want to have a life outside of my career. We talked about how you got to keep doing the things that you love when you're a physician. We all love love. You know, we all want to have love in our lives. So can please, especially the women on the panel, speak to that. Can we start with Dr. Williams?
Let's see. So I was not a psychiatrist when I found love. So I brought my husband from med school, and we met in college at Xavier. So I can imagine, though, that this question does more times than not involve the answer yes, because I've seen a lot of single older Black female psychiatrists. In fact, one of the most influential woman I know, she's single, and she says she just can't tolerate these Black men these days. And I know that that's not true, but this is what she says. And I've heard that multiple times. I do think whenever you're a psychiatrist, you just develop a certain view of the world, right? And you do things 9 to 5, you go through things, you have to deal with certain things with patients, and you just really don't want to have to deal with that in relationships. So I think that maybe that has something to do with it. But I think that across the board, this is something that a lot of professional Black women deal with in general. So I don't think it's just Black psychiatrists. I think that it's something that they deal with. So I don't know. I don't think I'm the best person to ask because I already had my love before I became an MD. So I'm going to go ahead and pass the baton.
I can pick up the baton as a single Black female in psychiatry. I think, honestly, I honestly never thought of it from that perspective. So if it has anything to do with me being a psychiatrist, that I'm not super sure about. But I do agree with Dr. Williams' point, though, that as Black professional women, we tend to, based on the statistics, have more difficulty finding a partner if finding a partner is your goal. And I do, from the other standpoint, though, want to encourage you guys that as a psychiatrist and in psychiatry residency, particularly when I'm on my psychiatry months, there's plenty of time to go on dates, plenty of time to meet people. We work, I don't know, maybe 10 hours a day. And that leaves a lot of time in the evenings. I get to go out to happy hours, get to go to dinner with friends, and there's a time and the space for it. So I think from that standpoint, I think be encouraged that as a psychiatrist, even in residency, there's the space to date. And I think the rest of it is, I can't guide you on dating, but there's time at least to do it.
I guess I get the last say. So I would say that it goes back to what I said in the beginning about, I mean, not in the beginning, but earlier about remembering who you are. Like, make time to do that. Make time to go on dates. Like, you do have time, make time to do that. I think this is way more than we can answer in 30 seconds. There's a lot about class and expectations and differences that you see in Black women, professional Black women, and professional white women, and their other counterpoints, parts, and different groups. So I think that we all will struggle, just physicians in period, knowing that unless you're with another physician or maybe a lawyer or a different career on your same par, like, you're going to struggle with this issue. And there's a lot of struggles about that and what you're expecting, what your expectations are. Like Dr. Williams mentioned, like, you hear a lot of women saying like, oh, I'm just not going to deal with that. I could say that I have known my boyfriend since I was in college. He is not in medicine. He is hilarious. He is like a jokester. He keeps me laughing all the time. So even when I'm sad or not having a good day, he's a way for me to escape medicine. He's a way for me to escape psychiatry. And I do get mad at him when he doesn't understand like bipolar disorder, but he keeps me laughing. We do stuff that's fun. We go on trips. We go and do things. And that really just makes my life better, having that component of remembering myself and doing stuff that I enjoy. So if you enjoy dating, you got to do it. You got to make time for it.
There you have it. There you have it. That's the thing. You make time for what you want to do. You try your best. You pray, because we all need faith. We all need that help as well, support system. And like I said, that was the last question. Chat's still going crazy, but we have to go. So I know I speak for everyone that's on this live right now to say thank you to our amazing panelists. Like I said, I've never had this opportunity like this before, to talk to 5 amazing Black psychiatrists doing their thing, showing love, giving back to the people coming after them. This is an amazing thing. This was beautiful. Thank you so much for volunteering your time, your energies. We laughed, we celebrated. This has been amazing. So please, reach out to them and, ask your questions that we didn't get to. But, we can't leave. I got to do some housekeeping. We appreciate your support for the SNMA and our membership. Like I said, this is the first installment of the SNMA Sowing Seed Specialty Series, 5 S's, alliteration, because we all about that. We love that. For those of you in the audience, please scan the QR code on the screen to give us some feedback. We want to know what worked, what didn't work. We want to know, what we can do better in the future. So please give us that feedback. The QR code is going to appear. There we go, right there. So please scan that and give us your feedback. Next, we want to pub our upcoming event. We have an event called Racism as a Public Health Crisis, discussing history, race, and gynecology. The Health Policy and Legislative Affairs Committee is putting that on. That's going to be another great, wonderful event. So please stay tuned for that right there on the screen. That's going to be on the date and time is there for you to read. And please, just like you tuned in for this, tune in for that one. It's May 17th. And then Also, we want you to follow us on socials. Like I said, follow SNMA on IG, on Twitter, on Facebook. Like us on Facebook. Follow all of these amazing panelists on their Instagrams and their Twitters. Please, we want to get our social media on and popping. We want to get it rocking. So please follow us everywhere. On IG, we're at SNMA_official. So please do that. Please give us your feedback. And yes, stay tuned for more of this. We got great webinars. Like I said, I'm the co-chair of the Academic Affairs Committee. So I have a wonderful team assembled. We're going to give you more webinars. We're going to give you, more things on ERAS and interviewing and all of that great stuff. We're going to give you more specialties as part of this series. So please stay tuned with us. And that's it. If you have, any questions, please reach out. Y'all stay safe, stay home, and have a good night. Be blessed.